I want to welcome you to the discussion today and to Brookings, to the discussion today about how communities and community institutions can boost neighborhood health. And I want to welcome everybody who's online watching this program today. Now, it's accepted, I think, generally that the United States is among the best among the best medical facilities available for anybody. But we're also recognizing that it takes a village to promote health in our communities. Local institutions and non-medical services like housing, schools, social services are crucially important in ensuring that, that communities are healthy. But unfortunately in America today, we spend an enormous amount of money fixing people and not enough on dealing with those issues and with those resources that are available in communities to help people be healthy. It's time, I think, for us to spend a little less time on fixing people and a little more money and time on reducing the need to fix them. For example, if you look at the amount of money the United States spends on medical care, as you probably know, we spend over 17% of our GDP on health service in this country, well above other countries in the world. But if you take together the amount we spend on health and medical services and social services and combine them, we're pretty much just a little bit above the median level in the world. So in the combination, we're pretty much in the middle. The issue is that of that proportion, of that total amount, the proportion that we spend on medical services as opposed to other services, many of which improve health, is actually extremely high compared with other countries. The average for the industrialized countries in the world is roughly, of the combination of medical services and other social services, the average is for countries to spend about 37% of that combination on healthcare services. In the United States, it's 64%. We're a complete outlier. We spend far more fixing people with medical care and far less than other countries by comparison in dealing with these social factors in healthcare. So this morning, we're going to explore this issue a little bit more with three panels. The first panel, which I will be joining too, the first panel will be looking at the role of social factors in improving healthcare in our neighborhoods and communities. In the second panel, we'll hear from some individuals who are tackling these same factors sort of in the front line and are involved in linking together social services and medical services to improve healthcare generally. And then to wrap up, we'll have a panel that will look at some of the implications of all of this for public policy and for the conduct of the way in which we run our health system in this country. Before we begin, I would just ask you to silence your cell phones so that it doesn't interfere with the broadcast of this event. I'd also like to thank the Aetna Foundation, which has contributed to support this event, and we're very grateful for that. And Dr. Garth Graham, who's president of the Aetna Foundation, will be joining us on the third panel. As always, I'd like to reiterate Brookings' commitment to independence and to underscore that all panelists will be giving their own personal views. The opening panel, as I said, I'll just be joining in a moment, will be moderated by my colleague, Dr. Kavita Patel. Kavita has many years immersed in both public policy and actually in the practice of medicine. She's a practicing primary care internist at Johns Hopkins Medicine at DC Sibley Hospital here in Washington. She's a non-resident fellow at Brookings and was previously the manager of clinical transformation at the Brookings Center for Health Policy. She's also been a researcher at the RAND Corporation. She served in the Obama administration as a health advisor in the White House and also on Capitol Hill, where she served on the late Senator Edward Kennedy's staff and among the senior staff of the Senate Health, Education, Labor, and Pensions Committee, which is the big committee that handles healthcare issues, along with finance. She will be moderating the first panel, and she'll be joined by Dana Matthew. Dana is a non-resident senior fellow here at Brookings Center for Health Policy. She's also a professor at the University of Colorado School of Law, at the Colorado School of Public Health, and at the university's Center for Bioethics and Humanities. She was recently a Robert Wood Johnson Health Policy Fellow in Washington and served in the office of Senator Debbie Stabenow. And last but by no means least, she's the author of Just Medicine, a cure for racial inequality in American healthcare. So let me hand over to
me. I know, perfect. I think you're going to. All right, so thank you, Stuart, and welcome to everyone, both in person and watching on the web. And what we're hoping to do this morning, Washington, D.C. is sometimes filled with a lot of chaos, a lot of noise, but we know that what really emerges from that are voices that can actually bring stories forward and can help us not only to think at kind of a very high level, but also bring that back down to a very practical level. So this morning, I think we're going to very much take you through that journey. And so I'm excited to not only be a part of it, but also to join two of my colleagues. And what we're going to hope to do for the next half hour or so, I couldn't be more pleased. And I'll tell you candidly, I've known Stuart now for, it's probably been going, when I met you when I first worked for Ted Kennedy, and so it's probably been about 14 years, and Stuart is very kind of understated, but Stuart was one of the first people, he will be the first person to tell you that he's not a healthcare expert, but what he really is he's an expert in kind of thinking about our country's problems in a variety of directions. And so when I first met Stuart, it was actually on this seems like it's a very appropriate topic for today and for this year, just the topic of access, health insurance, but in the context of budgets. And so in my mind, when I thought about Stuart Butler, I always kind of thought, well, he's the budget expert. And it's been over the last several years that Stuart's applied that knowledge in thinking about kind of economic and budget issues to healthcare. And I think what's impressive to me is that somebody who, I'm trained as a doctor, so of course I think about healthcare all the time. Somebody like Stuart brings a background that's very diverse, and he has really identified, and we're eager to get into that this morning, how he applies some of his knowledge of thinking on a national scale, but acting at a local level, and then also taking that lesson from the local context to the national stage. And then I have to say that Professor Bowen Matthew, who's right next to me, Dana is also, as I was doing, all of you are probably, you can Google all of us and see what Google brings up. Dana, I think, has been one of the preeminent scholars in really helping to push our thinking about health equity. Those terms sometimes feel very loaded, like, oh, health equity or community health or population health. What Dana's done over her career, and she's still young, so she's going to have more to do. What she's done over her career has been to really kind of push kind of consciousness about how our actual infrastructure of health really contributes to inequities in a serious way, but then how we can also be part of the solution. And because she comes at it from a legal perspective, she brings, by the way, this is like a limerick, a budget expert, a lawyer, and a doctor, and somehow there's like a riddle to be found in all of this. But I think the fact that the three of us actually are all kind of interested in the same problem, I think it speaks so highly to, one, that this really is a community issue, that you can't find the answers in any of our traditional silos. And that two, that there's really, I think there's a beautiful timing to this, because all three of us have come at this for very different reasons in our lifetimes. And I think there's just this great intersection. So I'm actually going to start, if you don't mind, Dana. I'd love to have you have written, both in book and in narrative, written beautifully about thinking about these intersections. And then I've read kind of, when I was studying healthcare disparities, I really had a hard time understanding how to bring that forward and how to think in my day-to-day life about healthcare equity and what we're doing to contribute to disparities unintentionally, or how we contribute to inequities. Just speak a little bit about your work and also kind of knowing that this is a policy audience, and there's people from the front lines here, because I know some of you, and there's people who work in policy sectors, nonprofits. Help us understand what we can take away from this.
Sure, thank you for the introduction. I love the part that I'm young.
You are.
I like that, especially. So this is a very knowledgeable audience, so I'll use some words that are probably known to everyone. But I originally come to the problem, as Kavita said, as a lawyer. And so lawyers are concerned with justice, a loaded word. Lawyers are concerned with equity and equality, not the same, but we're concerned with both of those. And so when I think about health on the population level, one of the things that concerns me most, both from the problem side and from the solution side, is inequity. Mm-hmm. Because if we don't appreciate that inequity means that resources needed to be healthy are inequitably distributed, then our solutions won't focus on the fact that that inequity will be exacerbated if we don't look at it. So when we look at neighborhoods and communities that are concentrated not only in poverty, but even modest income neighborhoods that have concentrations of under-resourced. So that would be food sources, educational opportunities, because the poorest schools are located in the poorest neighborhoods, employment opportunities, built environment where people can exercise, exposure to hazards like pollution. So you were talking about stories, and one of the things we're working on right now in Colorado is something called the Interstate 70 Relocation Project. Well, this is in a neighborhood. It's called Elyria-Swansea, where in the 1800s there was a smelting plant, so it's a Superfund site. There's a petroleum refinery. There is a pet food factory. There is the National Western Stock Show, and you know what comes with stock, located there. And now a 6-lane highway is going to be expanded to 8 lanes, right? So all of this is concentrated in a neighborhood. Now, you can guess the demography. Elyria-Swansea is 84% Latino, and 44% of the people are under 400% of the federal poverty level. So this community is repeatedly assaulted from an external and internal health perspective. If we don't look at solutions that are going to address the inequities, both environmentally and physically, then that community will be left out and health disparities will continue there.
And so we're, just to follow on, and then I want to bring Stuart in, what can we do? Because sometimes, putting that kind of consciousness out there, it feels like it's so hard to understand kind of where to go from there. And I think that's personally been a struggle for me. So where can you, and I know you teach, you're kind of bringing on a next generation of legal scholars, and I would argue more interdisciplinary focused scholars. What are you trying to teach them, or what are you trying to have them take away from like kind of that I-70 experience?
So there are two things. One, we have to think, of course, everything to a lawyer looks like a legal problem. So
You're good company in DC, by the way. A lot of people feel that way.
I would say there are two things. One of the things we're concerned about is more equitably distributing burdens and benefits. And then secondly, we're looking at new ways to pay for those benefits, right? So school financing is a great example. The way we do housing stock is another great example. One of the things that we have, this Colorado Health Equity Project, one of the things we're very concerned with is the fact that even though housing is becoming unaffordable in Colorado, we need to be thinking about mixed housing neighborhoods by zoning. That's a law. We need to be thinking about financing projects that will include multiple income families in one location. So these are legal problems and finance problems that I think we need legal and financing solutions to.
And do you find that on our next panel we're going to hear from one of the leaders kind of DC housing, so it'll be great to hear what's similar between Colorado and DC, and I know that there's a lot. Do you find that kind of also battling, we call it NIMBYism, there's certainly a sense of cultural kind of, people feel very personal, obviously, about where they live. Have you encountered that or had experience with the attitudes of neighbors and neighborhoods?
Yeah, absolutely. And the reason the I-70 corridor is a great example of this is because despite the poverty and the demography, this is a neighborhood where there are 4 generations of homeowners. So even though the highway project is going to displace 200 families, one of the questions is where are they going to go, right? So where are people who have had affordable housing going to go in Colorado, which is now one of the nation's 4th leading economy in terms of growth, right? Where are they going to go? Those neighborhoods are going to change, so social capital is going to change. that changes health, right? So social networks are going to change. That changes health. Availability of community affects health, and that's one of the things that I'm really excited about in terms of this conversation, that we understand that we're not talking about health anymore in an individual, what I call retail level, but we have to think about health in community so that we can affect populations, like the population in Illyria-Silencia.
That's great. And so, Stuart, let me ask you to kind of jump in. And so I know maybe perhaps, Stuart, you can set up a little bit of what you've been leading, not only here at Brookings, but kind of the conversations you've been leading across different sectors, to just give us some takeaways. Sure. And then also thinking about, just I'll tee up, I know I can tee up hard questions for both of you, but also teeing up for you, Stuart, kind of what is your prescription per se? Kind of how can we think differently about these issues at a policy level?
Sure. Well, first of all, thank you for your very kind comments at the beginning. Well, I'm actually a historian by background, and so I always say, the study of history is everything with examples. And so that's kind of in general, when I look at these issues, I tend to look across the spectrum and say what's involved in, what helps us understand a particular issue. And as you also mentioned, one of the things I've been doing here at Brookings is bringing together, in fact, some of the panelists, bringing together a number of people from very different sectors to really brainstorm on how can we understand what's going on in health, and also health in the economic sense of communities. Why do some people move up the ladder and others don't? How can we think about this and learn from each other and understand that to appreciate what happens in the health area, you've got to understand what's going on in these other areas, such as housing and transportation, as Dana mentioned. And we certainly have learned, if you look at the research in this area and the conversations we've had, we're certainly, I think, both here and in general, appreciating a lot more how these other non-medical factors influence healthcare. We're learning a lot about what happens to a child in the early years. Everything from stress to abuse and so on can have long-lasting effects on healthcare. So if we can deal with some of those issues up front at the beginning, then we'll have a big payoff, so to speak, both for the child and for our costs later on. We know, as Dana has said, that housing can be really important. If you have substandard housing, it's very much linked to things like respiratory problems, other kinds of problems. I mean, obviously lead paint, things like this we know about, but just dampness, poor neighborhoods, and so on. Falls, you think about the elderly. The Centers for Disease Control estimates that we spend probably about $30 billion a year fixing people who've fallen. And in many cases, this is an elderly person who's in an apartment, maybe with rugs that are slippery, or with a bathroom that is not really well designed, and it's more easy to fall and so forth. So a lot of these things are going on all the time. We also know that cultural issues are a factor. What's going on in a neighborhood, what the norms are. If people are smoking everywhere, younger people start to smoke. That affects them a lot. So we know that there are a lot of connections between these factors and healthcare. So partly what I'm trying to do is to look at what could you do to intervene in certain ways, to get these different sectors to start, first of all, to talk to each other, to share their insights, and to deal with a lot of the issues associated with where spending takes place. I mean, and let me just end on this. Take, for example, this issue of falls among the elderly. Everybody knows, everybody can appreciate that if we could do something to reduce the level of falls, it would have significant effects on the number of elderly people who end up in the hospital and end up in long-term care. Right. Long-term care now, nursing home care, costs, the median in the United States now is $82,000 per year. So if you can prevent somebody ending up in a nursing home not because they want to be there, but because of a medical problem, you can not only improve their lives, but have considerable reductions in costs. But our system is not set up to say, okay, if it's going to cost us $82,000 over here, why don't we take some of that money and prevent the problem over there? Right. Because what, of course, we find is that programs are not designed to do that. Healthcare is healthcare, housing is housing. So how do we start to look at budgets in this way? How do we look at rules for payments and so on? That's what we're really trying to dig in. So we've got a problem here, I think, of we've got to both understand the contribution that social institutions and social services in the community have to improve health and reduce costs. We've got to understand that. And then we've also got to understand that we've got to actually take steps to get these different sectors to start to appreciate how they can help each other, and also to set up a budgetary and payment system, an incentive system,
Right.
so that doing good is rewarded rather than very often penalized. When a hospital today does things that make it less likely that people will come to the hospital, that means their revenue goes down.
Right.
So, this is not the chief financial officer does not see this as a particularly wise use of money, even though it makes sense to everybody. And that's the sort of thing we've got to really tackle.
And so I'll ask you a little bit of the same flavor question. Because you've put out, and by the way, Stuart has been notorious for bringing these, I forget what you call them, like, is it strange bedfellows, or he's like they're called the working groups, but I know we've talked about the fact that Stuart Butler is known for bringing together people who should have been having conversations with each other all along. And I will confess that I find myself, when I've come to his working groups, kind of sitting there going, I've never had conversations with people, in housing or in some of these other social sectors. And I think that's been part of what's inspired a lot of our community-based work that we're doing even in the DC area. But one question for you, Stuart, we're at I do believe that we're at a very interesting nexus, because there is some shifts in payment policy, as you mentioned, to kind of promote these opportunities and have hospitals think very differently about care to be a bit more preventive, whether it's bundled payments or some sort of population health-based payments. So I know there are some financing mechanisms. Have you seen some other policy shifts that are allowing a little bit of that opportunity to think more preventive or upstream, so to speak?
Well, you're right that we've been taking some steps to kind of nudge these different sectors to work together a little bit. Some of them are sticks.
Yeah.
I mean, you look at, I was talking about the elderly, you look at Medicare, which now has, well, for some years now, has had a rule called the so-called readmissions penalty.
Right.
That basically says if somebody comes in and is diagnosed with certain diseases, particularly heart disease and others, and then the hospital discharges that person, and then they come back into the hospital, or any hospital, within 30 days for the same diagnosis, that initial hospital faces a penalty, in some cases a substantial penalty. Well, that focuses the mind somewhat.
Right.
And so now we're seeing more and more hospitals saying, okay, let's engage in a little bit of follow-up service here.
Right.
Let's make sure that when we give that, that wad of paper called the discharge, saying do all this, do all that, that we actually just check up and make sure they do follow up with their GP, with their general practitioner. Or even that we will go and see where they live and see if the fact they came in for a fall might be connected
to where they live.
Or maybe there's nothing in the fridge. Maybe this is a person has got, is 2 bus rides away from, the grocery store and just doesn't eat properly. Let's see if we can begin to make that happen, because we, the hospital, will face fewer penalties.
Right.
That's a stick. I mean, one would like to see more carrots and sticks,
right,
I
sure.
suppose.
Right.
But you're right. I mean, certain programs, the Medicaid program, particularly the managed care Medicaid program, where you've got managed care company or managed care projects that actually look across the sectors a little bit more. They're doing things to address some of these issues of housing problems and so on in order to get their general costs down. Health programs or health plans that are capitated, that have a membership fee or a capitated fee, certainly have an incentive to look at creative ways to use that money.
Right.
But and the rules for Medicaid are improving in that area. I think there's been a growing interest in connecting better between particularly the hospital sector, but the physician sector generally, and economic and community development a little bit better. And there are institutions, community development corporations, funders that are now looking at funding different types of activities and facilities to enable connections to be made more. There's a lot going on, and there's a lot of interest in using what we call intermediaries, those individuals who connect together different
the bridging
institutions. Yeah, I mean,
of these.
a good example is a school nurse,
Right.
for example, or a parish nurse, which
nurse.
in churches, and say, how can we work together with these intermediaries who know the people in the church, have got skill sets in the medical area, to work with the hospitals and physicians together. And the same with school nurses.
Right.
And this means addressing issues like data, access to information, and so on, and licensing requirements, payment systems. These are all necessary to do that. But I'm glad to say I think we really are seeing a much greater interest in looking at these issues. We're not necessarily on a roll yet, but we're beginning to get close to being on a roll.
People are welcoming the conversation.
Absolutely, and I think there's a great opportunity at all levels of government.
Right.
To do this.
And that's what I was just going to ask you, Dana. So you really have spent time, especially in the last couple of years, at a national level and at a regional and local level. What shifts are you seeing? And then this is going to be, I couldn't be at Brookings, and I promised Stuart I wouldn't talk about like the ACA or the HCA or any version of CA.
I didn't get that memo.
But you're right, Dana didn't get that memo, so I'm going to ask Dana. So Stuart and I are sick of talking about it. The truth is, Stuart and I get asked about that on a daily basis, I think.
I'm so glad to be the outsider because I can claim ignorance.
So I am curious, though, Dana, just thinking about the local, regional, national, and the very real conversation we're having about just what kind of access points and how we should think about whether it's state budgets and per capita caps or Medicaid allocations. How do you take the conversation we've been having for about a half an hour and then translate it to some of the challenges with access and then just even thinking through, we're talking about potentially entering people into high-risk pools, and I would argue maybe that I-70 corridor is probably going to have a concentration potentially of people who are falling into that. So tell me, even if you've just internally thought about this, how do you wrestle with that from an equity perspective? And what guidance can we give to people as they're also wrestling with these issues?
Thank you for
a real easy question.
I was going to say every time I'm
going to let you talk.
Pause there. I'm
going to let you talk to the United States Senate if you can figure this out because they need your help.
I think I'm going to focus on how we pay for things.
That's fine.
Right?
That's perfectly fine.
Because in fact, even as Stuart was saying earlier, there is a stick and a carrot approach, but all of it involves dollars. Right. All of it involves how we reimburse payers. Now, some would argue that there's an over-medicalization of poverty and over-medicalization of these social problems. And I really resist that and suggest that one of the shifts that we have seen, one of the heads of steam that we've seen is that people in healthcare, physicians, providers, understand that, I think it was Rudolf Virchow that said this, it is self-evident that a physician or a provider's science must include everything, every aspect of life that is proclaimed purpose, that is health, touches, right? Everything. So it has to include housing, employment, income, and so forth. But it can only do so if we reimburse those providers in a way that gives them time and incentive to pay attention to those other factors. So one of the things that I've been writing about and thinking about is why hospitals, especially safety net hospitals, are not leading the charge to protect the Medicaid expansion, right? They should be leading the charge, not only because the head of steam that has allowed them to diversify their interest and create these collaborations that Stuart is so good at bringing people into the room, that should be happening on the ground, right? We should see more Catholic hospital initiatives working with Mercy Housing of Denver to create medical respites for the homeless, right? So that we can reduce the return and readmission. Why? Because there is a financial incentive to do so. We should see more collaboration between those who are addressing food insecurity, like the Boston Community Hospitals, right? That have both farmers markets that people can get to transportation-wise, as well as cooking classes, right? And educational components. that will reduce chronic disease from a preventive side. But why don't we have this? We don't have it because we are still reimbursing per member per month, right? We're still reimbursing people in a way that incentivizes them to think about illness instead of wellness, that incentivizes them to think about individual healthcare as opposed to population. And so I really do think that the leverage or the lever that we must address is making sure that financing is available. That's why I say hospitals should be leading Medicaid expansion, the fight to protect it, whatever the, political changes to the ACA or whatever follows it. If we lose the ability to be creative about looking at bundled care, about alternative payment methods, if we lose the amount of money that is addressing vulnerable communities, then all of the head of steam is going to go backwards.
And I just may add a couple of things to that. I think one of the challenges which flows from what Dana said is, first of all, it's hard for a physician to be knowledgeable about everything.
Right.
And for example, now pediatricians are being urged more and more to ask children about their conditions at home, poverty, housing conditions, and so on. But they're not always sure what to do with this information. So that's one of the reasons I think the role of intermediaries is really important. It's really important to have a kind of a cluster of people and organizations around the health system and really close partnerships so that when a physician spots a potential problem, they know how to give what we sometimes call a warm handoff to somebody to address this. And we're beginning to see this, hospitals, as that I mentioned, doing this. The second thing I think which is we're going to have to deal with and challenge is that, what is the money spent on? When you look at something like Medicaid, I think an increasing issue is if we really wanted to do this effectively and to have the various aspects that lead to illness taken into account by the Medicaid program, we'd have to start using Medicaid dollars for different kinds of things than it traditionally has been used for. That makes a lot of people understandably nervous.
Right.
Does this mean that money intended for people's health is now drifting into other areas? What does that lead to down the road? We'd also want to have more flexibility generally about the use of that funding. Well, talking about the healthcare debate going on, there's a big debate over should states have greater flexibility in what they do with Medicaid. A lot of people get very anxious about that.
Right.
But the positive side, of course, is to say if they could, there could be a lot more exploration of ways of using what's now medical money to fix people in a way to deal with their health issues. These are difficult issues, and politically very. So it's, we're on a roll in one sense, but it's a roll that's kind of bashing into some walls here and there as people think about what could go wrong with this picture.
The unintended consequences.
That's the issue, I think.
And I know Stuart's going to get into this with our concluding panel, so I don't want to steal too much of their thunder, but kind of the national implications. I mean, really, it goes back to, I think, Dana, what you put it very beautifully, this kind of I-70. I've driven on that highway. I know exactly what you're talking about, kind of this analogy, because we now are finding that our communities, in an ironic way, we're so connected because it's constant, whether it's social media or this or that, and I told people I finally joined the Facebook. For the longest time when I was in government office, I could not. I was not on the Facebook, and my own mother kind of forced me to be on the Facebook because once you have children, it's the only way that she can see pictures of them, and so when I finally joined the Facebook, my sister sent me a text. This was literally like a couple weeks ago. She's like, "Welcome to 2008." So I am probably the worst connected person in the entire universe. But the irony is that the more connected we are, actually, the more we're struggling with inequities across. I would almost argue even more kind of more lines that we're now seeing much more social isolation. We're seeing much more of a sense that even if you're in a community, there's a sense, and there's a very palpable sense in this country that you don't know where to go for help. And I don't know, so we're going to go to the audience in a second, and we've got two of my favorite people in the back with mics. So if you do have a question, I actually just want you to put your hand up so that we can get mics to you, and then I'll call on you. But Dana, just give us, I want to close out the panel before we get to the questions with just your thoughts on bringing it back to the community and kind of where you think, you mentioned a little bit of kind of people in the built environment, food access, insecurity, employment, kind of how do we think, is there a framework we can use to kind of think about, is it bringing people together? What are some ways forward as a community that you would say, okay, we're doing it? I would say what Stuart's doing with his working groups is a great, one potential. Are there some other things you've seen that work to just bring people together to solve these problems?
I'm afraid you've invited me to sort of wax lawyerly eloquent.
That's fine.
So
That's good.
I have to say I love your word connectedness, right? Because in a lot of ways, one of the things we've seen in the I-70 corridor is a lack of appreciation for how important it is for communities to connect. So I-70 is one of two interstates that goes through this historically Latino community, I-25 going north-south and I-70 going east-west. So that bisects the community, and that means people can create food solutions like a farmer's market up in the northwest corridor, but I got to take 2 buses and take off from work to get to that food solution. That community's not connected.
Right, doesn't matter.
And it doesn't matter that I've got this great food resource. That's what happened in Flint, quite frankly. Flint, we hear about the water crisis, but again, transportation, another health issue that's underappreciated, right? If you bisect a community, you put solutions out of the reach of a community, and then they have to use the fast food stores that are very dense and available.
And they're right there.
They're right there. The bodegas, they're right there. We have got to think of connecting communities, and then lastly, sorry to get philosophical, but all communities are connected to one another. Right? We all bear the cost of premature death. We all bear the cost of excess emergency room visits and readmissions. We all bear the cost of under-resourced, low and modest income communities. And if we think that we can isolate those problems from the whole, then we're missing the picture.
Great, perfect. And I know we've got some questions. Yes, sir. Just if you can tell us who you are and just your question.
Okay, I'm a student at Howard University. My name is Jordan Sellars. I liked you all's narrative. This is kind of like the wedding before the funeral. But in terms of what she said specifically about how can we alternate solutions to this problem as far as healthcare is concerned, it seems that there still needs to be a study done given the fact that healthcare for males or females is kind of the same thing nowadays. We're talking about, whether you're a married couple or a single or you're a heterosexual or homosexual couple, we're talking about the same needs and wants. So really, how do you, say that there isn't a problem with healthcare if you're giving the same type of healthcare to people in the healthcare community and there really is no debate and argument from them?
I'm not sure I'm smart enough to know what that question was asking right now. So you're talking about how do we know if there is truly a difference in healthcare between persons? I just want to make sure.
So the analogy was like, this is the wedding before the funeral. So if you're going to provide healthcare for couples, whether they're homosexual or heterosexual, it's like healthcare is trying to get them premium health care if they're already, celebrating something that's going to benefit this particular couple, but they're not giving them long-term health care if there's going to be, like I said, a wedding before the funeral, life or death that could happen. So it's like, where are we going with solving this problem if the social science isn't saying that healthcare as it's being provided doesn't cover life to death?
Oh, I see. Okay. Sorry. Now I understand. All right. So do any of you want to just tackle kind of thinking about, I'm just going to kind of paraphrase a little bit just to give a pointed question. Just how do we think about the need for the kind of longitudinal, and that's where I think you were arguing that we need to actually study this, that we're looking at healthcare and kind of different time constraints before what is really a longer term vision for healthcare.
Well, we certainly, I think, some years ago began to recognize that health is a continuous process, which is what I think we're getting at. Because when you have a health system, for example, that's heavily and still is heavily employment-based, for example, the incentives for an employer thinking about what health to give to their employees is going to be different from somebody looking at that whole period. So as we've tried to move towards healthcare being connected to the person rather than where they happen to be or where they happen to work, that's, I think, been a very important step forward. We've also been doing a lot more research in over the years now in looking at when you intervene at a certain point, or if something bad happens at a certain point, how does that affect people over the long term?
Right.
And what can we do in these areas? And I think that's been one of the reasons that, particularly with regard to, say, children, that this focus on social determinants and what goes on in those neighborhoods has attracted the interest of people in the healthcare community, not just the social science community, or the sociology community, because it does have these long-lasting effects. It's the same as the debate over early childhood education.
Right.
Where does the benefit show up? Is it long-lasting? Is it short? And so forth. So I think in general, we've seen the healthcare system, or people researching in the healthcare system and practicing in the healthcare system, like these other sectors, like education, like social science and so forth, beginning to look at this continuum. And I think that's the core, in a way, of what we're talking about here today in this panel. What are these issues and factors that influence are going on in the early period that may end up, causing the wedding to be a funeral, or causing problems, or leading to a really good outcome? And how do we learn from that?
And I think the question, I think you're exactly right, that we don't really set up studies or think about things in that longitudinal way. I know
we're getting better.
We're getting better. I mean, Stuart and I know this. Stuart probably doesn't even remember this. When I worked for Kennedy, one of the things that I approached you and Hank Aaron here at Brookings about was the fact that we couldn't actually get the Congressional Budget Office to think that way when we were looking at interventions that would have an effect. Early interventions, even on a healthcare front, that could have those downstream
researchers,
effects.
like everybody else, tend to be rather siloed. It's difficult, even within the health area, to get people to really focus on the long term. When you start saying, okay, if I'm a health analyst, how do I start thinking about housing and education? So literally, people in these fields often have really very little knowledge about the databases, about the research in these other sectors. And so actually looking at the return to an investment of focusing on something which is non-medical in order to improve the health over the long term. Sometimes it's actually very difficult to find somebody who looks across those sectors to know what the data is, to get the kind of research needed. And that's kind of where we are now, I think, trying to find better ways of looking at returns on investment across sectors to show the impact on health.
I want to just say in response to the question, I don't know if you meant to, but you put me in mind of one other thing that we don't talk a lot about, and that is the community's role in defining research objectives and the community's role in defining what kind of healthcare choices we make. One of the things I appreciated so much about being in Senator Stabenow's office during the Flint water crisis was that the first call our staff made was to people in the community to say, what can we do to help you? And some of the answers were not what we expected, right? So some of the things that we needed to research were not exactly what we would have done in our own Ivy Tower kind of research generating. We would come up with different solutions if we asked the populations that we're serving.
And people don't even take the time to do that. That's your point.
No, we don't.
Very few people.
I don't know if you meant to say, but when you asked that question, I was thinking, well, sometimes I just go in my corner and I think about what I want to research, and really I'm driven by what data sets I can get, and that's what I'm going to research. We need to ask people who we're serving.
And flipping that model to bring the kind of data we need is actually something we're going to get into a little bit. So let's go over here to this side, and then we'll flip to this side, this lady on the end.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney. What you're talking about are called the social determinants of health. And there's been lots of study of that. And of course, overseas in Europe, they do it much better. What I'm concerned about is for-profit, not for-profit. I think we are medicalizing things that shouldn't be medicalized. The difference between the visiting nurse service, VNA, and for-profit home health agencies. In VNA, though it used to be, at least when I was using it, a nonprofit. It was an institution where the nurses and the people who weren't nurses, they had a promotion scale, they had benefits, they had teaching and learning so that you could advance your career moving up, and it was not for profit. a home health agency, which often provides the same kinds of services. They take immigrants, they give them a couple of weeks of training, they have no benefits, they have no future, it's a dead-end job. When they're disabled because they've tried to move a heavy person, they've taken out their backs. I had patients like this. Well, they're just discarded, and new people are brought in, and all the intermediaries make money. The people who run the agency, the hospitals who employ them. We need to build community institutions like VNA, sort of like the nation building that we did in Afghanistan. People need to work with the community to set up nursing, social work, that everyone can access and everyone supports. The hospitals shouldn't be doing population health. Population health is a public health problem. The solution to obesity is not talking to your doctor, but like tobacco, public health initiatives, reducing advertising, putting calorie counts on food. That's something that President Trump just withdrew, or the FDA under President Trump just withdrew. Think about profit, nonprofit, and community institutions, which I understand is what they have in Europe.
Any reactions? Any just thoughts?
Well, I think our emphasis on what we're talking about here, and certainly the work we're doing here at Brookings and elsewhere, is very much focused on those institutions. I'm not absolutely convinced it's a profit, non-profit issue so much as one where how do you actually get the incentive structure and the skill sets in place to enable a good outcome. I think particularly with regard to community-based institutions, we're seeing an improvements and addressing some of the issues associated with education and training of, say, nurses to play different roles and more expansive roles in the community. I think we're looking at how to get better partnerships with exactly those institutions you referred to in those communities. That is the kind of thing we're doing, and I think where the effort is being placed to address those specific issues that you raised. You're absolutely correct about the ingredients, the things that need to happen, and to begin to kind of work in that area. I think whether it's a federal issue so much, I think we'll get into a bit later about to what extent it is the place to see these things moving more locally and thinking of ways of permitting it to happen, not removing things that get in the way may be an important factor. And I'd just say finally that I think there's a lot of interesting experimentation and initiatives about more localized efforts to build a village, to build a team in this way. We see it with things like community schools and communities in schools, which is setting a team in the school to look at these different things and to try to work together. We see it here in the District of Columbia and also in Boston and a few other places in the growth of senior villages, which are institutions in the community, a mixture of volunteers and some professional staff to really address the multiple needs of elderly people trying to age in their home and addressing all these issues. So I think it's coming. I think you're absolutely right to emphasize those concerns, but I think the good news is that we're beginning to see some activities in these areas and some institutions growing to address the kind of items that this questioner asked.
Any brief thoughts, or should we just move on to get
I
some...
see the word brief. I just want to say
I
one
know.
thing.
I'm trying.
Very,
I just want to get as many folks in.
I don't want to, I absolutely respect your experience. I want to push back just a little bit. It doesn't have to be hospitals. Stuart and Cameron.
Although I'm here to tell you they have money they should be giving. So I'm just going to be an advocate that hospitals should play a role because they should. But
Okay, well that's
we'll
probably,
get into this in the next panel.
She did it for me.
Exactly.
Hospitals don't have to, but they are a hub, to use Stuart and Cameron's word, that is a really good choice and possibility. Not the only choice.
Right.
Schools could be a hub. The point is to bring collaboration around public health problems. Right. There is no institution alone that can do it, and no institution is absolved from it doing it, is my point. And so I'll leave it there, and maybe we'll have a conversation offline about my clients who are also patients, and will only come to see the lawyer in the clinic. They will only come to see the social worker in the clinic. So the clinic, the healthcare provider, is a hub that the community respects and that the community relies on. And so to bring those services into the public health services into the clinical space is very effective.
Gentleman over here in the front, and then I'm going to try to make sure we can get to everybody. So we're going to try to be very brief. Yes, sir.
Thank you. Sandy Apgar, CSIS and Brookings Metro. Have any of your study groups or programs looked specifically at the best performing non-US programs to really identify practically what works, what doesn't? The structural differences are fairly well known, but having spent almost 10 years in the UK in the last decade and actually experienced and lived the National Health Service and so forth. As a capitalist, I came back very much geared to a national single-payer system in the way they've performed it. But although I've seen studies, but have not focused as you all have, about the NHS and its counterparts in other countries, I've never seen a direct, business-like clinical comparison of the practical levers of what makes them work and what is somewhat dysfunctional. The three observations I would make as a former client, patient, and so forth in that system. First, ours is far more complex for the individual consumer and patient.
We now know that.
And the obverse of complexity, of course, is simplicity. As any business knows, complexity breeds cost. It's inherent. And when you begin to simplify complex systems, you can carve out costs. The second is specialization. Our system seems to be so specialized that alone for a general patient or consumer client is a real problem. And it gets in the way. The silo effect is very obvious. The third is institutionalization, as distinct from individualization. We felt very much individual healthcare consumers and patients in the UK, much more than we do. And finally, cost consciousness, which is all of the above three, tend to diffuse the attitude toward cost. It still is phenomenal to me that when a general practitioner or specialist recommends X as a procedure, and I ask, what's it going to cost us? He or she
I couldn't tell you.
Cannot respond.
Right.
And if they do, it's always with 10 caveats. Well, we don't need that as individual consumers. We need people who deliver care who, yes, know it is costing $1,000 or $10,000 or $50,000, and then can be aware of that. So observations plus the question.
All right.
Question you guys.
Do you want to just take that briefly?
As the resident expert.
Exactly. I hear your accent, so
I've spent a little time in the National Health Service. I think you're certainly the last part of your question, your observation is right on in terms of what some of the differences are. I think there have been a lot of studies that have looked at, medical cost effectiveness across and medical systems across the world. Much less on what goes on in communities that has these implications, which is similar to here. And we're not as aware of that. When you look at that, there's also cultural issues that you've got to sort of try to factor in. Certainly when I spent many years in the UK under the NHS, and the role, for example, of the local district nurse, which is a person, an individual in the National Health Service, which is kind of virtually unknown here. It's a little bit like a parish nurse. We're groping towards it here. But this was a nurse, a highly trained nurse in the community, whose job it was to make everything fit together. And not only within the medical sector, but dealing with other sector. My mother used to run a post office in the UK many years ago. And the district nurse would come by her every day to get intel on what was going on in the community. Mrs. Jones, who normally came in every Tuesday, hadn't come in. So the district nurse would literally bicycle off to see if Mrs. Jones was okay. And sort of, that's something we don't really have here, but that's a central feature of the NHS, irrespective of whether you think, single payer is better, we don't have people like this. And then I would just say, yes, you're right in your first point about we in many ways in the United States are the most over-regulated and most highly regulated system. Simplicity counts for a lot. Simplicity, flexibility. Complex rules are the enemy of flexibility. right? You just literally cannot do certain things. And that's so often what we encounter here. And it's, dealing with that is part of the solution. And giving flexibility and reducing restrictions, it doesn't mean you get substandard quality for exactly the reasons that you mentioned.
Dana, final thought, and then I know there were other questions. Some of these themes will come up in the next two panels, so just please reserve, and we'll try to get to you in the next two panels. Just final thoughts to kind of round us out.
I'd like to end by saying I'd love to see private and public streams of financing come together to address this problem. My favorite model is social impact bonds right now. Crazy about social impact bonds. They do wonderful things for food in Brockton, Massachusetts, and so forth. But I think what Stuart has called it is, and he's not the only one, of course, but I've really been impressed by the writing that he's done about braiding and blending public and private streams of financing, because we have to be able to do this apart from government regulation. We have to be able to do this at various levels of community. And so looking at ways for the two sectors to combine would be a really good solution to start with.
Well, join me in thanking both Stuart and Dana. Thank you.